Hey, welcome back. You're on the Faculty Factory podcast, and I'm Kim Skorupski here at Hopkins, looking at one of our former professors, Dr. Sanjay Desai. Hi, Sanjay. Good morning.
Good morning, Kim. It's so great to be on this podcast with you and to see you again.
Oh, you're so kind. Folks, Dr. Desai is the Chief Academic Officer at the American Medical Association. And we know Dr. Sanjay Desai. You heard his name mentioned on the podcast when we were recording an episode with Dr. Ben Kinnear. And Ben just mentioned casually Sanjay. And I said, well, I know Sanjay. He was one of our people. And sure enough, Dr. Sanjay Desai, for, more than 20 years, I guess, was at Johns Hopkins. He was our Myron L. Weisfeldt Professor of Medicine. Love Mike Weisfeldt. He used to be the director of the chairperson of our Department of Medicine. And my neighbor, he and Linda, lived a couple blocks away from me on the harbor here. He and Dr. Sanjay Desai was the director of the Osler Medical Residency Program and the vice chair for education. And Sanjay has a spectacular reputation as being one of those really important thinkers around medical education, innovative programs, and just one of these kind of cool guys everybody talked about because he was kind of ahead of his time. And so the American Medical Association wooed him away from us, but Dr. Desai kindly volunteers 4 weeks, I think, at a year, and he comes here and he sees patients. So I'm so happy to see you back, Sanjay. And I think I remember when Ben was talking about you, and it reminded me all the important work and just the foundation and the principles of why we're all in academia. It's about education. You know, the academia is rooted in education. And so we're all teachers. If we're in the formal, traditional classrooms, or we're at the bedside, or we're in the hallways, we're in the lab, we're in our patient examination rooms, we're all educating and being educated constantly, right? So I love your article in April Academic Medicine. Just recently, April 2024, Academic Medicine, the premier journal in academic medicine, rightly titled. And the title of that article is Precision Education, the Future of Lifelong Learning in Medicine. So Dr. Sanjay Desai, I'm so excited to hear what you have to talk with us about today. And I'll just let you lead the conversation.
Kim, thank you so much. You're so kind, first of all, with that introduction. And I could say similar accolades about you, just witnessing personally the impact that you've had at Hopkins in faculty development, well-being, and a whole lots of other strategic initiatives that we've had. I thought I'd give a little background on the American Medical Association and its role in medical education, because I think probably for many, including myself, before I really got engaged with them, are less aware of their footprint in education and in the production of physicians. And so this dates back, well over 150 years, their role in education. And we have a mission statement, which is to improve the health of the nation using medical education. And we look at medical education as the goal of it is to produce a physician workforce that's capable of caring for our patients and communities. And over the course, again, of the organization, they've had a number of different roles, but really it's distilled down to just a few now that are that have quite a bit of reach, though. One is we, along with the AAMC, co-sponsor the organization that accredits MD granting medical schools in the country. So there's a role in accreditation that we sponsor. The second is, and I think this direct relates to faculty development and faculty in medicine, is the continuing medical education credit system is the American Medical Association Physician Recognition Award, or the AMA PRA credit, which is what people earn when they experience and take on CME.
Oh.
So we have a direct footprint also in continuing medical education and which is core to faculty development and teaching and continuing lifelong learning. So those are really I think important administrative roles that we have in both ends, if you will, of medical education. And the third, and I think the way I got engaged with the AMA is in their innovation arm. So the AMA has made it a core mission to think about how do we improve the education system, really working at that leading edge of innovation. And over the course of the last decade plus, they've invested mostly through grants over $40 million in medical education. So one of the largest that I'm aware of in the country in terms of its investment in medical education directly. And so I learned about it because I was fortunate with Hopkins to be the PI on one of the grants that we received, along with Stanford University and University of Alabama
That was
in
the
Birmingham.
Reimagining Residency grant?
Yeah, exactly. And so we were a group across three different universities that were able to the fortunate recipients of a grant from the AMA, and then we were looking at innovative ways to assess where people are in the hospital and then relate that to well-being and to clinical skills. And so that's just an example of the work that they've done. But the history of the grants programs that we've had, we worked first on UME, so medical schools themselves, and thinking about how we might improve the experience for medical students. And that led to a lot of engagement across the country. And we developed this consortium of medical schools that now has grown to well over 75 schools that have that work with us, including Hopkins and many others. And for the UME side, the focus was on health system science. And out of that has come several textbooks on health system science and faculty development on health system science, including a scholars program where faculty from universities all across the country have participated and learned how to teach health system science and really become more skilled in that. So that's been a really nice, I think, output of the UME grants, along with other work there as well. It moved on to what's called Reimagining Residency, and that was 11 different grants that have gone out to even more universities because many of them are partnerships. That's the grant that we received with Stanford and UAB. And that's about, again, thinking through how do we innovate across the GME paradigm. And there's a whole host of different types of themes that are there. The assessment is one, competency-based medical education, which is really core. That's part of the UME grants as well, has been part of that. Equity has really become a core part of this. And these grants are still going on, but they're starting to wind down. So that led us to, I joined just about 2.5 years ago, and that led us to start thinking about where do we focus next? And that's where precision education, as you already highlighted, has really come up. And what we, I think, have observed is there's a lot of room for improvement in medical education. As we said at the beginning, we said that it's meant to develop a physician workforce capable of caring for patients and communities, but we recognize, and there's all kinds of, these days, there's all kinds of data on how we're not doing that as effectively as we need to be doing that. There are underserved communities across the country. The entire way that we develop physicians it's inefficient. It's high cost, high resource, and particularly that long arc that you primarily focus on as well, which is faculty development. That long arc where it's most unstructured. How do we make sure that people are continuing to stay at the forefront of what they need to learn and their skills and attitudes and knowledge, and to help them care for the patients that they'll care for, but also help them teach that next generation of physicians. And so that led to precision education. It's the idea of using data and technology. I think, led into this, thankfully, right at the time that AI has now started to come up as well. Obviously, in the last year has really changed the world already and will continue to do so. But we think the short definition, Kim, would be that we use data and technology to personalize education, to make it more efficient. There's a lot of unnecessary friction in learning in medical education. And third, and I think this is really important for faculty development as well, Kim, is to transfer agency of learning to the learner. And what we mean by that is really no longer should we rely on the institutions or the systems to decide what you learn when, but to actually give that empowerment to the learner with data so they know what they should be learning. But then to take more control and agency over their educational experience.
I want to pause here, Sanjay. I'm hoping that maybe people will hit their rewind a couple times to hear what you just said. You just jam-packed a lot of really cool, important information into what you just said, and it's really powerful. And I can imagine a couple hours of us talking about a lot of this stuff. That said, since we don't have that kind of time, could you point out as an example, what is some unnecessary friction? I
Yeah.
love when you said that because we know we're all about faculty first. In the world of faculty affairs, faculty development, it's all about faculty. And you can't help but draw me back in the day when the AMA came out with, physician well-being and wellness and all that. How many of our institutions, as you know, our colleague Lee Doherty Biddison is our chief wellness officer. They came from the AMA movement of burnout. And so tell us more about some examples of what is the unnecessary friction in the education space that hampers development and agency around education.
Yeah. No, I think it's a great question. And I think there is this, what I'll describe, Kim, is not unique to medical education, although our structures have certainly amplified some of it. But I think you see it in other professional education, you see it in K through 12 education. But examples would be, first of all, we have this structure of medical school, residency, and continuing practice. And while we hope that it's meant to be a continuous journey of development from which people can have this steady development of competency, we are far from that. It's highly compartmentalized. And so there's friction. The first source of friction is that each of these compartments right now is primarily designed for as a one-size-fits-all, relatively random experience generator. And so regardless, for the most part, of who steps into the medical school, what they receive and what they experience is either designed for everybody or delivered to them in a random fashion. And that, so the easy example would be that someone that comes in with a major from biochemistry in college and someone that comes in with public policy, they're going to sit through the same classes. And so there's going to be moments where one individual is accelerating their development and the other is decelerating in their development. And that's not efficient. And that creates friction in learning because we want continuous development throughout. Another easy example would be the transitions between these compartments, Kim, where the information about an individual is not shared with fidelity across that transition. And so you almost start, again, randomly, or certainly without insight on this learner. And so there's a plateau at best, and there's a descent at worst in terms of competency development that occurs between those transitions. And then finally, if we go to the practicing physician, there's tremendous friction in the way that we have created, well, let me say this just for the practicing physician, because I think it's so important. It's hard for me to imagine another group of people who want to learn more, those that have chosen this field. And yet we create this environment where it is really hard. There's so much unnecessary friction. I say unnecessary friction because learning is friction. Learning is part of that is friction. And that's good. But the part that encumbers the learning is bad. And so as a practicing physician, and any faculty listening to this, I don't think I have to get into the details of where that occurs, but it occurs in the hospital, it occurs in the clinic, it occurs in the, when they teach others because of all the forces that are there to separate them from that teaching mission. And then it occurs for them personally because the structures, generally speaking, that the structures and processes for continuing medical education are not well aligned with workflow or patient relevance. And so, again, tremendous amounts of friction that we need to start addressing. You talked about burnout, and I know you've done so much work here, Kim. I believe this is a core contribution to the experience of burnout that physicians feel. Is this friction in their lifelong learning journey.
Amen, Sanjay. Amen. I'm so excited to hear you talk about this. And I mentioned to you earlier that several years ago, maybe, I don't know how many years, it doesn't matter, but Charlie Irvin, he's from Vermont, and I gave a talk at Chicago, the AAMC Group on Faculty Affairs annual conference about precision faculty development. Because when I had learned about precision medicine and started learning more about precision education, I thought, gosh, it's the same thing. And you put it so elegantly, this idea that in faculty development, we're committing the same sins We have these wonderful programs that we design with best intentions. And then we start, say, for an example, this leadership program, 40 people in a classroom back in the day when people came to classrooms, and say, how many of you have you already done the Myers-Briggs personality profile? How many of you have already done this 360 or that Clifton strengths? And hands go up. So that's the friction you're talking about, that we're like, really? We're going to spend this much time doing something I've already done? Let's get down to business. We're all at different stages. And so that's also why it's so maddening, as someone who lives and breathes faculty development 100% of my time and for like 18 years, when we see, and I'll put air quotes around, other centers or shops or outfits or offices who offer faculty development, or they call it, professional development, but it's so generalizable, so generalized, or so generic. That's the word, generic, that yeah, it's a great instructor, it's good content, and yet it fails to recognize where all of our faculty are at that moment in time and what they need. But then that's the paradox. How do you know? So Sanjay, back to you. I'm going to hit this back over the net to you. How do we know? How do we assess where are the data coming from, and how are you collecting the data that tells us, okay, here's Kim Skorupski. She's done this, that, and the other. She's figured out how to build teams and collaborate and communicate, and yet she still has opportunity to work on that abrasive style where she talks too much and she comes across as steamrolling and she thinks out loud, and so we need to work on that. I mean, how do we bring and meet people right where they are and deliver that education in time, at the moment, can implement it directly, measure it? Donna Beating's famous structure process outcomes. Where are those outcomes? All right, now I'm getting excited.
Yeah, no, this is a great example of where the deficits and gaps are. And this leads directly to precision education, Kim. I think one of the problems, or really prohibitive challenges for faculty in this era. So you mentioned about how we do the same thing to faculty in terms of their development, and that's true. At the same time, for faculty to teach and develop their residents and their students, or their peers even, I think that one of the biggest gaps we have is we don't provide them the data and the insights about their learners, about those that they're teaching. And so they spend a lot of time either just delivering what they think should be delivered, or trying their best to assess where people are, which is really, really challenging in the infrequent, limited exposures that they have with those learners. And so it often leads, unfortunately, and I think this is a cultural problem. Kim, you could probably speak to this better than I can, but there's a cultural legacy of this deficit mindset where when we're with learners, that we either think that they're, they get it or they don't get it. And if they don't get it, they're not good enough. As opposed to what I think precision education can do, trying to specifically answer your question, is it would present insights to faculty about the people that they'll be educating. And so everything, what you just described, that, this person here has this profile of communication experience and really needs to develop their ability to effectively talk about end of life issues with families. This other person over here actually has really gaps in clinical reasoning, particularly around these types of conditions. This other person over here, they show up late all the time. There's a professional issue, or they can't complete their notes because of their workflow. And so these are three different insights that I'm just using as examples. So as a faculty person, that if I have high quality data on those specific competencies that we have deemed as meaningful in the journey of this person, that instead of spending my 45 minutes with them or my month with infrequent exposure with them, trying to figure out where they are or just delivering what I want to deliver, I actually can work with them on those specific things. And so that's an example of how faculty can deliver differently with data. That though you asked about data, and I'll answer that in a second. But I think similarly for faculty development, we have to do the same thing. We need to understand what those development needs are for faculty. Those data should be available. They should be consumable, and they should be actionable so that we can deliver, because even if it's the same communication issue that one person needs to learn or another person needs to learn, again, using this mindset of abundance, that we have an opportunity to grow people rather than they're not good enough, is one thing. The second is, even if they have the same communication issue, one person could be in an ICU, the other person could be in a clinic with oncology patients, the other person could be in a prison working with those that are those are very different ways of communicating. So I think, again, understanding there's a lot of nuance that we need to be able to collect, aggregate, and analyze to then provide interventions that can be most helpful for people. And the last thing I'll say before I pause is the data. So the data are everywhere. And I think this is the opportunity, though, with AI and with all of the advances, this inflection point that we're experiencing in technology, is that it's not possible for humans to take this abundant data and make meaning of it in the way that we now can using these technologies. So the opportunity would be to use data that are in the EMR, use data that are in the learning management systems, use data that are in the payer systems. There is, again, a whole in using natural language processing out of the notes that are there. We believe, and there are already use cases for this, that I start to identify signals across these competencies, not with a person doing this, but with a machine doing this. And those competencies, those insights then should inform the types of education that faculty and that learners should get.
Oh, Sanjay Desai. Yes, yes, yes. My hands are up over my head. I'm so excited to hear this. It was just,
I can see them up there because I can see you. I know the listeners can, but I can see them.
I'm so excited because I was just, gosh, it was last week, and it's something, I can't remember what it was. Somebody asked me for something via email, and I thought to myself, as you get older like me, one amasses so much information, so many file folders, so many emails, so many documents. And I thought, why can't Microsoft Outlook, or some little GPT thingy be looking over my shoulder, so to speak, and seeing, oh, Kim, I read this email coming in from Dr. Sanjay Desai. He's asking about the podcast and the book. Is this the attachment you want to send to him? Is this the email that you'd like to forward him? And I'd say, yes, little robot guy, that's exactly the email I'd want to send to him. Please do so. So that kind of ability to, as you were saying, natural language processing made me think, let's get the tools to help us find stuff. I mean, many of us, the data and the information are abundant in that regard, and it's hard. We waste time, I think, finding stuff. So I'm like, that would be such a cool thing, but also creepy. And there's a creepy element to like someone reading a thing, an entity reading our emails, but saying, hey, it's almost like a chore list. Every day I coach, dozens of faculty members who have their inbox jammed with emails, and it's almost like a to-do list. They have to go through these emails and do the thing. But wouldn't it be wonderful if the thing were being done for us, that you would just say, of these 10 things you were trying to keep track of, what you have to send, look at, read, attach, and do, just want to verify, is this what you meant to do? Just like in the EMR, the records where we have, I'm sure up in JHCP there, they have these smart Johns Hopkins community physicians offices. Dr. Moore McGuire was telling us they have smart rooms where you go into the room and the room starts recording the conversations, and it's already pre-populating Epic. So those kind of tools and that kind of AI as a resource, I think, is just so incredible. So I'm all excited about that.
Yeah, no, and I would add to that, Kim. I would say that there's the practical side that you described, how it'll make your workflow better. But I think that there's an equally powerful, perhaps even more powerful opportunity around generating insights about someone that can help them. So it's the unknown unknowns, so for example, I know that I don't know X, and therefore I will go try my best, hopefully, to learn X. But I don't know what I don't know about what I need to learn. And that's where I think there's an entire opportunity for us using these data. And in fact, you said finding the data. We call these found data. These are data that exist. It's just pulling them together and using them in a way that they're for a different intent
Yeah.
than what they've been collected for, and for education in particular. Again, it can help with education, but it can help with patient care. Ultimately, all of this is for patient care. And so I was just in the ICU last week, and we've come across conditions that I haven't seen in some time. And so if there was the ideal situation would be that I would get bite-sized information that's very patient relevant, that is designed for the way I consume information, that will help me care for that patient tomorrow. And right now I have to go seek that out. But the future would be that would be delivered to me.
That's exactly it. And I can't help but thinking, gosh, why aren't we there yet? And I think it's we know those data are there. We know just by personal example. And the example I was also thinking about this weekend, I was helping someone. I have in my DNA, thanks to my mother Scarlett, this gift, if you will, or a curse for organizing. It's a gift, it's a blessing and a curse. But I was helping her organize, and because she had so much stuff, she's like, "Oh, I can't believe I just bought soap and I'd forgotten that I had 152 bars of soap because I go to Costco, but I didn't know where I had put it because I didn't see it. It was stuffed somewhere. It didn't occur to me that I had it." So
Yeah.
that kind of triggered the same thought for me. Many of us, how many times do you noodle around in your computer and come across a file folder and go, "What in the heck is that?" And you go, "Oh my gosh, I forgot all about that." That's a whole treasure trove of stuff that I've stored, a bunch of bars of soap that I forgot I had. So I went out and bought some more soap, or I'm seeking out stuff that we already have that we don't know we have. So it's not the unknown knowns or unknown unknowns. It's the
Yeah,
forgotten,
yeah,
the forgotten
yeah,
knowns.
yeah. That's
But
funny.
I like what you're saying about. I want to kind of get back to this whole thing of agency, because we all know on a personal basis, which means then we can take it from the micro to the macro. We know these data are there, that we know that there should be some system of organizing it, like someone handing us the file folder, the handoff. When I go in to see the patient, I got everything, snapshot history, up to date, current state of affairs. Some AI has updated everything. So there's not even a need to ask the patient, what vitamins are you taking? And I'm like, I just answered that 13 times in 3 different surveys. Why don't we know this? But how does a learner, a faculty member, a leader have that agency when it's just so much stuff? How do we
Yeah. I mean, I think that
operationalizing that?
there are, so you mentioned, why don't we have this? I think these innovations are starting, and they're occurring. One of our goals at the AMA is to help nurture this ecosystem and try to connect people as best we can, and try our best also to set some principles and guidelines around this work, because as you could imagine, much of this innovation occurs in institutions where there's resource. And if that continues, the default future will be that there'll be a small number of institutions and there are a small number of beneficiaries of that innovation. But we want this to be a public good. And as such, we want to make sure that these innovations can be replicated and scaled. And so having some conversations and some organization of the space is one of our goals, to help catalyze that, and push that forward from our perspective. But an easy example of how agency can be conferred using precision education is the idea of a dashboard. So if we use the dashboard for residents as an example, a resident in any specialty will see lots of patients over the course of months, or certainly over the course of years, but likely doesn't have a analysis of the types of conditions that they've seen, the severity of those, what if they're procedural, then what types of parts of surgeries that they've actually independently contributed to or performed, and how competent they were. So all of these data, these are voluminous data. And they need to be organized and presented in a way that is actionable and creates insights. And that's happening now. So there are, so Ben Kinnear, who you mentioned, is doing this for, there's a use case out of University of Cincinnati where they're working on this for those that are admitting patients with complications of diabetes. There's a group out of University of Michigan, but it's a nonprofit global organization called Simple that Brian George is running that actually does this at scale for surgeons. And actually that's now connected now to the American Board of Surgery. So these things are happening. They create these incredible dashboards that provide insights at a very personal but very meaningful level for someone. And in our view, the best use of those data, so you confer agency by sharing it with the person whose data those are. But in addition, you create development by having a coach also visible that has visibility to those data so that you have someone that can help you make sense of what you're seeing and create or inform a development plan for you and continuously iterate on that to make sure that we're improving along the way. So I think those are the ways to confer agency using data.
Beautiful.
Actually, the last thing, Kim, I'll just say also, we've been talking the entire time about individuals, but I do want to make the point that our model for precision education has different levels of application. So it can be the person for sure, but it can be a program. So residency, you can imagine, gets agency by collecting and seeing insights about the types of residents that types of physicians they're producing into practice. And then health systems can do this at obviously a greater scale by looking at the workforce that they're developing and getting insights about that.
Yeah, genius. I had no idea about these other use cases. As you're talking, and I'm not an MD, so I'm thinking of patterns that before data, before computers, physicians got really good at recognizing patterns and seeing this phenotype, this patient is presenting with these symptoms, therefore it's like a decision tree, making very quickly, if it's this, then likely that, if this, then that. And so one could come to generate a hypothesis that this is most likely this disease, this condition, based on pattern recognition. So our own brains were generating those conclusions. And I think what just seems to me is that using technology to get to those patterns and then the anomalies, that's where the beauty of this is, because there's just so much. And I'm also thinking, I like the way you talked about the feedback, the coaching model, because of course, so many of us do coaching now, is if we think about physicians like professional athletes, and so the athlete is practicing on strength and endurance and flexibility and all kinds of conditioning, like a physician who's doing a procedure in an operating room. If you do that, physician doing the procedure, the professional athlete is doing the training or practicing to get that feedback of how's my body reacting to this? How is my performance affected by this difference in diet and nutrition and this new speed drill I'm doing? That feedback, that coach is giving that feedback, and the athlete is getting the performance indicators on the court or in the field or wherever they are. I feel like maybe in other industries that's been mechanized or it's done more legitimately, or what am I trying to get at?
Yeah, maybe more deliberately. I mean, what we're doing, so yeah, we're as we're pushing in precision education. So our goal at the AMA is we will be launching a whole host of investments in this space because we do think this is the future of lifelong learning, to leverage these data and technology innovations to improve this educational model. At the same time, we are pushing also on coaching. And so we've just published a book of coaching in GME. We had coaching in medical students earlier. And so I think developing the coach along with so the technology is just a tool. That's how we see it.
Right.
It's the humans that are going to be using those tools and the human structures and processes and environments in which these tools can be deployed that we need to really focus on while the tools are developed. And so developing the tools is one piece, but we need to develop the coaches. We need to, Kim, I think you're, again, more of an expert than I am on this. We need to really move the culture of learning to a different space where people can consume these data in a way that has this frame of growth mindset, that has the master adaptive learner outlook and approach to them. And I think because we have a system that has these high stakes transitions, it requires a change in culture. But I think the data hopefully can catalyze some of that change and move us forward.
Oh, Sanjay Desai, brilliant, brilliant, brilliant. I love this work. I'm so excited about everything you're doing. It's the future. Thank you for using that big brain of yours to actually do stuff that makes absolute direct application, makes great sense. To me, it's a beautiful thing to watch and to learn from you. I so appreciate everything you're doing. And I would love to have you back because of course, my brain is on fire now. I want to have more conversations with you. Anyway, I'll stop talking now. But
you're very, very kind, Kim, and I just want to thank you for having me on first, and also for doing this. I think having a podcast that encourages people to talk about this and is disseminated so widely, it's very impressive, and my gratitude to you.
Well, thank you. And then the AMA is so fortunate to have you. I learned a lot about the American Medical Association. The Chief Academic Officer, Dr. Sanjay Desai. Sanjay, thank you again, and we'll see you all next time on the podcast.
Thanks so much, Kim.
Hello, everyone. It's your podcast producer, Casey Calnan. Please make sure to download for free our newest Faculty Factory book, The Academic Medicine Starter Kit, Timeless Tips and Guidance for Early Career Faculty Members. More information on that is available on the facultyfactory.org homepage. In addition to that, I wanted to let you know that as of June 2024, this podcast has had more than 85,000 total downloads and roughly 11,000 total YouTube views. And in addition to that, the Faculty Factory website has drawn 46,000 web visits from users in 122 countries. And we're inviting you to be a guest on our show. Please reach out if you'd like to be a guest or to nominate someone in our academic medicine community that you think we need to hear from. Visit us on facultyfactory.org and drop us a message there.
Thanks for tuning in to Faculty Factory Podcast. The mission of the Faculty Factory is to build and support a community of leaders in faculty development who share tools, resources, wisdom, and encouragement in service to our faculty members, schools, and institutions. We encourage you to go to facultyfactory.org to find out more. Get in touch with me, ask me any questions. Maybe you want to be interviewed on the podcast. Thanks for tuning in to Faculty Factory Podcast. We'll see you next time. The Faculty Factory podcast and website is sponsored by the Johns Hopkins University School of Medicine Office of Faculty. For more information, visit facultyfactory.org.